thanks Sanjeev as usual for conscripting me. Whether I want to be here or not, I have no choice. And Dr. Vinita has set the to-do list to me here while I was planning to escape immediately after my session. So here goes. May I call the chairpersons for this session, please? Dr. Shobha Mudgal and Dr. Vijay Patil. Dr. Shobha Mudgal, neither need any introduction. Dr. Shobha Mudgal leads CPA, the first two chairs? I've got a feeling we're going to be short of chairs. Shubha, as I was mentioning, leads Cancer Patient Aid Association, one of the oldest organizations. Dr. Patil absolutely needs no introduction. Professor at medical oncologist at TMH. We have a panel of patients and doctors, and we have a person who's both a patient and is a doctor. So we're trying to look at various aspects to see how we actually get to understand, as Sanjeev mentioned, what are the issues that people have in lung cancer. Everybody here is obviously aware, but maybe if we get an all-round perspective of what we are, this will help us to plan our growth chart ahead. We know when we talked about the digital progress that we are making, the idea is to connect not just patients who come to Tata, but patients all over the country who need this kind of support for lung cancer. And considering the Tata Hospital itself has grown into so many other locations, that would be our first step, to engage patients over there. But the idea is to provide the support that we have managed to succeed in growing over the past 6 years. So without wasting too much time, I know we have time crunch. Let me just call the panelists on the board, please. Dr. Amit Kumar. Dr. Amit Kumar from Medanta Hospital and I think on a hardship posting in Muzaffarnagar at the new TMH center, which I believe works out of Porter Cabins. Maybe we'll give him an opportunity to explain how things work. I think he is too extreme with Medanta at one end and the Muzaffarnagar center, he'll be able to tell us more. Then we have the father, Mr. Premchand Jain, Karthik's father. Mr. Jain is here in the capacity of a caregiver. His son is under treatment at TMH. Betty. Mr. Parab, Chandu Parab, I don't see you. Laplat. Paila nahi tumhala. Yeah, again, somebody who doesn't need any introduction, officer in charge of the medical social work department at TMH. Every patient at some stage or the other has, I'm sure, been to the department and seen what sterling, compassionate work they do. So we have him here always to be our balancing factor to get the ground realities of patients and doctors. Mr. Ravi Prakash. Mr. Ravi Prakash is a patient. He's a journalist with the BBC. I think he's ideal person to be part of our growth chart, I'm sure. Thank you for being here. Mr. Jaffrey? Nahi aaye? Okay. Dr. Sameer Nanavare? Dr. Sameer is the person I was mentioning who's here, I wouldn't say wearing two hats, but who can give us a perspective from both sides of the table. Thank you for being here, Dr. Sameer. Lekika Sonkusre, yeah. Lekika has been with the social, psychology department as a med counselor for a number of years in TMH. We are so used to seeing our most familiar Savita that we don't realize it's not just one person, there are many people, and I'm sure she can give us a very, very good picture of the ground realities of the problems patients have from a counselor's point of view. Mr. Vikas Havaldar. Mr. Vikas Havaldar, again, a patient who has played a sterling role in the growth of the support group in for Lung Connect. Thank you very much for being here and for all that you do for all the patients. We have someone who's new here, Dr. Rajam Iyer, who's a pulmonologist, a specialist in palliative care. We just thought we need to bring in this really important aspect of care, end of care patients.
Thank you.
Yeah. And also, since we're talking of a network, to be able to give us a perspective of the network of palliative care available throughout the country. So we are trying to look at same issues from both sides, from the patient's perspective, caregivers, and the perspective, of course, is an aspect of the patient, and from the medical angle, and, or shall we say hospital, because we're looking at other people besides the treating doctors as part of that. So if I can just ask Dr. Here comes our hero. Yeah, I have a very special question for you. Baad mein puchungi. Dr. Amit Kumar, perhaps you could give us some idea of the current treatment modalities, and since you're working in two different places, a perspective on what it is that you find different and what is it that you find common in both the setups that you are in.
So yeah, I'm working at two places. One is a complete corporate private patients, and the other is at a government setup where the patients are not at all affordable. There's few things different. If a patient comes to Bombay and get treated, it means that the patient and the family all are very much motivated at least. Whether they are not affordable, that's a second issue. Even if they don't have a money, but the motivation is a part in the society that they want to get treated. So only those patients are coming to Bombay or going to Delhi from a remote area from Bihar or a West Bengal. But if they have a large chunk, I will say only 20 to 30 patients are migrating. 70% of the patients are there, still staying there, but they don't have that motivation or the social support for which they can come to Bombay or to Delhi for their treatment. And those patients need the maximum help, I will say. But there is a challenge also on the part of the NGOs also, because you cannot give support to anyone who is not receptive to it. The more thing is the patient who got lost to follow-up, they are less in Bombay or Delhi as compared to a patient who comes in a hospital, say like in TMH Muzaffarpur, or there's a Mahavir Cancer Hospital in Patna. They have got a huge chunk. Their yearly registration is something around 20,000. But those patients are those, the family just come, they want to show in the society that they are coming to the hospital, getting treatment once, and they mostly in 2 to 3 months, patient lost to follow-up. But because the most common is obviously poverty is the most important thing, their family don't have the power to support also. Because if 2 of the attendants are being involved in the patient care, there are nobody to earn in the family. So these kind of patients, we need to give just a support. Because I'll say they in the verge that they cannot devote too much time, but still they want to do it, but they are not able to do it. So the thing I will say in a state like Bihar or anything, in a poor state, even if a patient doesn't come with a single penny, still there are methods now, I'll say in India, that I can give them treatment. The only question I ask them, whether you want to take treatment or not. If you are willing to take treatment, there are now ways. So as a ma'am has already discussed, investigation is the most important thing. So any government support comes only after when there is an investigation, the patient is proved to be a case of a cancer, and is a proof that he has got a particular type of cancer, and then the treatment has to be given. So for treatment, there are many one who are supporting. But for diagnosis, there is no support, I will say, at present. So that's the major lacunae in this support program. That if a patient is coming with just a chest X-ray showing a mass in the lung, but how? When he'll go for a CT scan or a biopsy, all these will be going to cost something around 30 to 40,000 rupees. But there is no support for that. So most, I'll say, some 20 to 30% of the patient doesn't even go for that diagnosis also. So if we provide that diagnosis chunk in this group of patients, they can get further support because there are many channels. I'll say in India at present, for any cancer, just have to navigate the patient to a right place, they are going to get some support. Every state government is going to support the patients, but even the state governments are not supporting the diagnosis part. So I'll say that even in Bihar or in West Bengal, the state government is giving from 1 lakh to 5 lakh rupees for the patient's treatment, but that only comes after when the patient is diagnosed with that.
Yeah. I think, Chandu, Ms. Parab, perhaps you can throw some light. And I know in Lung Connect, one of the issues that I think Dr. Nuran also brought up is funds for investigation. So, Ms. Parab, if you can give us an insight in which would, I think apply to all the Tata hospitals, if nothing else. I mean, because that is where the poorest of patients do actually seek treatment.
In our hospital, basically patients don't know what hospital is serving for them. So first we'll explain the patients how we are giving a cheaper rates, maximum concession we are giving in general category. So first we'll explain the patient, and who is not affording for that concessional rate, we will change the category from general C to nominal charge category is a NC. So that charges is more or less than other categories. Plus, if patient is under investigation in initial phase, that time we are giving a 10,000 support for initial purpose. See, patient will come to TMH for treatment or investigation, and he first day back out, then it is very difficult to us. That's why we are at least giving a 10,000. That is, 10,000 is completed the initial investigation, and we'll get the idea which treatment we are providing for this patient, and then we are providing for their treatment support, whatever is available in our hospital.
So I think, Dr. Mudgal, since you are in this, you can perhaps also throw light on this. The two issues, basically we are talking a motivation, which I'll ask Lekhika to speak about later. But, I was just wondering, if I know you all do help with the funds, so how exactly do you think is there a way that, we can overcome this barrier of getting funding from the beginning for a patient?
Okay, so CPA raises funds through our own events. We're also getting CSR funds. I think all NGOs now depend a great deal on CSR. It's a wonderful new initiative that was started by the government, in which a portion of profits of each corporate, I don't have to talk too much about it. I think everyone knows about CSR funds and how important they've become. So CSR funds, what happens is that right at the beginning, when you're asking for these funds, you have to put it down as being for a particular requirement. So if you start out saying that I get 100 patients, they're coming from rural areas, they don't have the money to start even with the diagnosis. So they come with a X-ray. So, that is the way that we can work backwards. So I'm aiming to learn a lot from today's conference on how we should be writing our CSR projects to better address the needs of patients. So this was...
Yeah, I think this would really be useful if we are sensitive to what exactly are the needs of the patients. Yeah. So, we need to know how we can divert. As we know, there are CSR funds available. People are looking for good causes, and nothing can be as important as a timely diagnosis for any disease, So instead of people dropping off treatment for that reason or delay it, I think this is very important.
The issue which Amit raised is important because normally what with for us the issue is that for any cancer treatment, whether it's lung, head and neck, or breast, we need to have investigations. And the first investigation is for diagnosis that this is this cancer, because the whole treatment actually depends on that. And apart from that, then there are other bodies of investigation which are for staging, on which again the type of treatment, that selection, whether surgery, no surgery, that depends. And then the other types of investigation, which is for whether the patient is fit for the treatment. So this the broad category of tests which are required, like for diagnosis, for staging, and for this. And now that with in cancers like lung cancer, we also need testing which are molecular to select like which, if you are going for chemotherapy, which is the chemotherapy which would benefit the patients. So the thing is that unless we have this information, it's very difficult to proceed further. So this is like the step one. So if the patient doesn't takes the step one, he cannot take the step two and step three.
That's right.
Yeah.
So which is where there's also loss to follow-up, people dropping off because they can't afford. And as doctor said, we always say, because even with my work all these years, that it's people who can afford that train ticket to come to Bombay will come to Bombay. If they can't afford that, there is no treatment. Now, thanks to hospitals coming up all over the country, there is hope of treatment. But if funding still remains, if they're so poor that they can't afford to come to a larger city, or they're not motivated because they realize the realities of being away from work and so on, if the other pockets also get the kind of funding that is available, I think it'll improve, it'll be a load off larger hospitals in bigger cities, while help improve, availability in different
So if I can just add, that CPA did actually start this about 3 years ago. We targeted CSR funds for non-Bombay locations. So we have now reached 51 hospitals in 16 states.
Excellent. Yeah.
So and at
ICS
each of
also
these,
does that, yes.
at each of these places, we have created a contact person who then identifies people who can do. And we've done this in remote places.
So all this is really important for our information cell in Lung Connect, whatever can be sort of taken. I think Mr. Jaffrey is waiting to say a word.
Actually, what he's trying to say is, is a very pertinent, because after my tenure with Tata, I have been actually going around the country, and I have seen that there are so many patients who are not even knowing what to do. Investigations are, a little further part also. And as he correctly said, that there is no money with them. So, and there is no even facilities available for them. I think so this, whatever you people are doing, will be a great help. But please advertise it as much as possible, because if you do not do that, people will not come to know. Like, I am also coming to know first time that you have got so many rural centers you are talking about. Everybody should know about it, and patients do come from all over India. And now there are many centers in India which are actually trying to come in with the National Cancer Grid.
That's right.
As we all know.
That's right.
And we can actually associate these people along with this. And the basic thing which he again is saying is, and I agree with him, is that people do not come to know that they have cancer till the time it is too late. So, and because they don't have the money, and when by the time they come to know, it's too late for anybody to do anything.
Yeah, maybe we can have Lekhika please give a perspective. He talked of motivation, and we have a couple of patients here, we have caregivers. So if you can just say that how early does the intervention of a counselor come in for patients? And if you have some idea about lung cancer, that will be better. How early are you all called in to try and speak to patients or this thing? And also, if Mr. Jain could give a perspective, what motivated, how they, from a caregiver's point of view, how they have tackled the psychological issues, the problems. Mr. Jain, we'll have her opinion first from the hospital, and then maybe you can just give us your views.
So, when patients or caregivers come to us with a lot of psychological issues, that, for example, that they have initial reactions when they're diagnosed with cancer. So they have earlier emotions like they have fear, they have distress, they have anxiety, and so many issues are there. So first that we allow them to ventilate their emotion, and then first they will be comfortable for their emotions so that they can look forward for treatment. So our role is to minimize their distress related to cancer and some psychosocial issues, so that they will be more comfortable to go for treatment and that further steps. So this is our primary role. And then that role, that it goes extended, that they have other issues, because issues in every step, that issues that during diagnosis, then the treatment, and then post-treatment survivorship, But whatever the requirement at present that need to be evaluated, that need to be assessed and intervened, that is more important. So the motivation to go forward, motivation to treat first their trauma related to diagnosis. So that is more important. So to make them free for further step.
Thank you. Mr. Jain, anything to add from a patient's perspective or, a diagnosis is always difficult for the family as it is for the patient. So were there any particular challenges of communication within the family, trying to get the best possible support and so on? Did you have challenges and how did you overcome them?
It is very, at the first moment, it is very difficult to accept that now we have got a patient in our thing. But main thing is hope we should not lose.
That's right.
But that is the basis of the everything. If we start losing,
No, I think it's fine. Just a matter of holding it, I think. Just slightly if you hold it closer.
so that is the main thing. And best thing is to join the groups.
Yeah.
Because
yeah.
then only we will be knowing, because otherwise there are so many, once there is a cancer, everybody thinks now
That's true. That's true. Getting support
So,
from within the community, is
community,
really,
within
really
your
important.
relatives,
I think because,
everybody thinks it is a very bad thing. And
yeah,
like that.
I know.
It's a disease like any other disease now.
Yeah. I think he's touched upon an issue which I think Dr. Samir, maybe you would be, he says it's a bad disease. There's some kind of a stigma,
Yeah.
it's a bad disease. And I dare say with lung cancer, we were actually, Lekhika and I were discussing a little earlier, that there are two issues. One is, largely we know we associate it to tobacco. If you hear anybody has lung cancer, the first question, is he a smoker? Was he a smoker? That's the first question which crossed our mind. So there is, I guess, that guilt issue which may come in if somebody has been a smoker. But then we know there are a large number of people of both genders who have never been smokers. So then there is the why me? Why is it that this happened to me? So, Lekhika, if you can just throw in, and maybe Ravi Prakash, if you can just, or Dr. Sami, sorry, I asked you. Please go ahead.
I think I'm the perfect combination. For
Absolutely,
this panel.
which is why I said
For
you're
this panel,
both
being
sides.
a patient, a caregiver, and a clinician, all three into me.
Exactly, which is why I thought you were the
Thank you.
perfect person to
Yes.
ask this question.
So, what I completely, as a clinician or a caregiver, sometimes you suddenly feel that you are immune to everything in life till something comes to you, whether it's cancer or anything else for that matter. And when it's cancer and you're suddenly faced with cancer and you're on the other side of the table now discussing about your case to somebody else, then you tend to understand what happens when a patient sits across to you on a table. So what I would feel is what he rightly mentioned, hope is the word, because even I was into stage 4 metastatic cancer from which today I'm sitting here. So at one point of time, you have to realize that you are a patient. And you have to accept that. Then you have to keep your clinical part and your doctorate aside, and you have to get into the shoes as a patient and start accepting what is coming to you. Okay, you have to keep the hope going up, but at the same time, you have to let go and give into the caregiver. At a certain point of time, you cannot be a doctor, you cannot be a clinician, you have to be a patient and just follow what has been told you. And trust me, because of that approach, probably I'm here today. Otherwise, being a doctor, you have a lot of things in your head. You can conflict wherever you want to. You can discuss wherever you want to. But at some point of time, you just have to believe that what is coming to you is right, and just follow the journey.
And as we all know, we have Dr. Google at everybody's
Yes,
disposal.
exactly.
I mean,
That's
that
right.
he's
So,
he's
yeah.
the best or
And-
worst
and
doctor
as a
in the
doctor,
world.
so I was much more than Google. So I had we could go anywhere. But at some point of time, you just have to accept what is come to you, and keep the hope and believe in the person who is treating you. Because you have multiple things coming from multiple people and multiple doctors for that matter. Forget the family members. Just that's how probably things go ahead and you overcome things.
Yeah. But I was wondering specifically if you have encountered in any of your hats, as we talked about there being a stigma against somebody having cancer, or a patient having a degree of guilt, or a why me? I mean, how would you? And I'd like Dr. Rajam to come up with your views after that.
So why me means I was a non-smoker, so why me also comes to me. But probably it's a process of life. And as you face a lot of things in life at personal levels, at professional levels, this is one thing that is a part of your living, and you just accept it and just move on with that.
Yeah.
Thinking about it, why and who's and why's is probably just going to let you down mentally. To keep in this situation, you need a lot of mental strength anyway. So more than listening from anybody, talking to yourself and thinking that, okay, this has happened to me, but it happens to everybody. I mean, when I used to walk into Tata, I used to see patients and people, and I said, okay, I'm just one of them. And I'm no more a doctor, I'm no more a pulmonologist, I'm just one of them. And I have to follow what these people do. Nothing different for me here. And trust, that's actually what has, made me reach to where I did, because my case was actually very challenging. And I am very thankful to Tata, because that's a place where I have actually survived. Otherwise, in the best of the places in Mumbai, wherever I could go and I could approach everybody, there was a dead end at a particular point of time. And Tata gave me an opening. And that opening is actually what has made me reach here. So I'm very thankful to the institute. And of course to the doctors, Dr. Kumar Prabhash, who's been a pioneer with me in this.
The caregivers. So I think what Madam was trying to say is, I think also cancer kind of gives you an emotional diagnosis of the clock ticking backwards. I mean, I think when you diagnose a patient to have any form of cancer, the next question that pops up in his head is, how much time do I have in this world, or what all do I have to do in the short time do I have? And I feel that is the thing that we as doctors and clinicians really fail to miss. And like Samir mentioned, who is my junior from Nair, I have realized the importance of empathetically connecting with patients and caregivers only when I have been on the other side of the table. As a doctor, it's very different. You somehow are, the best thing that happened to mankind. I mean, nothing can go wrong in your life. And it's very different the way you see the patients and the caregivers. But once you are the patient stroke the caregiver, life looks different. And I think that's the empathetic shoes we all need to fill in as doctors, and it's important to inculcate in the training. So I think point number one here is that we really need to be sensitive to this health-related suffering that our patients and caregivers undergo, and we really need to listen. And like all of you will agree, doctors wait to open their mouth. Do not let the patient and the caregivers talk their history, as we call it, and we are known to interrupt within 1.8 seconds of the patient opening their mouth. So we really need to get to their level, because honestly the disease experience is something they have, and every patient teaches you something else, and we really need to listen. So I appreciate, yes, I think somewhere cancer is not more stigma, I think it's a more emotional diagnosis, because of the fact that maybe there is Bollywood, maybe movies which has dramatized it and made it so, like, oh God, it's the end of the world. And we really need to make an effort, and it has to be a team effort between patients, caregivers, oncologists, palliative care physicians, clinicians, as well as NGOs. So I think we need to work towards that. And I sincerely think, wearing my palliative care hat here, we, just like everybody else here said, hope, guilt, finance, frustration, fear, the spiritual pain of why me, all this is something that palliative care physicians can address. So my humble request is to go to most important for clinicians and as well as doctors you all work with, is to integrate palliative care as early as possible. Palliative care is not just for end of life and for active dying. We focus on improving quality of life of patients, and most importantly, we let the clinicians do their work and handhold the patients and the caregivers for all the questions they have, and then actually work as a team with psychologists, social workers, volunteers, physiotherapists, and all of that, because all of us comprise together. So I think it has to be a teamwork, and there is so much going on in the family of a patient and the caregiver that if you take out one thing of I am there as a friend, whatever the outcome be, just make the journey more comfortable. I think that's the most important thing, because like Samir would and the other patients and caregivers would vouch, just having that person saying, talk to me about anything. It could be a very, very small question, large question. Just to have an answer at the end at a decent time frame makes a big difference for the patient and the caregiver to be supported through this difficult time.
Yeah, I think Vikas, if you can just move to him. Vikas has done sterling work as a patient, I think navigating the Lung Connect group has been a large role. And I also want to just, when she spoke of palliative care, as we said, not rightly, we usually consider it to be end-of-life care, and it isn't. It's something which can come in very early, symptom management, control, getting the patient in every kind of comfort, which helps the rest of the treatment to act. So one aspect which comes in, which I'm going to also throw to the doctors, is the use of complementary and alternative therapy. Now, as a lesson for dummies, I don't mean anybody who doesn't know what the difference is, but complementary is when you add something to the treatment, which could be something like yoga, meditation, various other things which come along with the regular treatment which is happening. Alternative is trying a field which is totally different, a different course of medicine altogether, what is not being prescribed by your doctor. So because because from what I understand, discovered that yoga helped him tremendously during his treatment and decided that this is one way of connecting with the patients. Can you just tell us a little more about the complementary therapies that you have been using as a part of the lung support group?
Thanks, TMH, for calling me over here. I am as a patient, lung cancer patient, and from last 3 years I am surviving. And the first, during the discussions, we were listening one word, which is a hope. That hope, you have to keep always hope. The first time when you detected this, when I detected this cancer, that time first few minutes or say 5 minutes, I was under what will happen to me and all that things, and my family is there. But I have to keep the hope. And then second thing is then when after coming to my family, then family discusses, and then we have gone to my family member advised me to go to the yoga teacher. So I have gone to the yoga teacher, and he gave me the confidence that because through the yoga, a lot of rishis and all those things, they have survived for the 100 and more years. So such type of disease can be also cured, okay? Because this is a lung cancer, which is a lung connected with the oxygen. And lung connected with the oxygen, which gives you have to do the pranayam. So this yoga, I have started the yoga over there, and it gives me a lot of confidence that through the yoga, there are the 4 to 5 yogas we have to do. Daily you have to spend at least half an hour. I think half an hour is more than sufficient for the pranayam and these things. If you can do more than that, 45 minutes or 1 hour, that is also fine. But this yoga gives a lot of, it improves your lung capacity because of the oxygen inhaling. And this pranayam, I always been talking to our, during the meetings also, that we have to do the yogas. Now, second thing is that when you are saying that hope, and if you see the lifespan of the lung cancer patients, it starts from the 1 year to the 14 years also. So why 14 years? Why not 20 years? Because once you survive for the 3 years, there will be advanced medical facilities will be available, new research are happening. So definitely with those research, your life will go and prolong. You can prolong the life with that. So that keep a hope on that. Keep a hope on the patient, doctors. Whatever doctors are suggesting you, whatever the dietitians are suggesting you, you follow the same thing. And I think by following all the doctors and dietitians suggestions, you can survive from this. Definitely. On the last meeting, only one motivation was there. There was some, Ms. Zarina was there, and she was saying, I am cured, please give me the confidence. So Mr. Vandana Mahajan has given the confidence, yes, you have been cured. So that was very much motivation to us that yes, now lung cancer also can be cured. It may be maybe 4th stage or 3rd stage, but see, one thing is in mind that whatever the doctors are saying, that is what is the survival life. Because of the current research and current study on the lung cancer, they are saying all these things. But day by day, there is new research is happening, and I am sure that cancer will be like a regular disease. It can be cured. That type of disease will be there because of the good research is happening.
Thank you, thank you.
Thank you.
Ravi, yeah, thank you so much. Ravi, if I can just ask you a few questions. You're from the media as a journalist. A huge role to play, and a huge role to play with Lung Connect for spreading the word. You know, for giving, we've learned so many positive messages here, motivation, hope. As he says, it's a matter of taking each step at a time and going forward. So how do you see your role in getting Lung Connect, on a national basis, and what are the other ideas that come to your mind as to how it can be done?
Thank you, ma'am. Actually, we are giving our outputs to improve Lung Connect. हमने कई सारे इंटरव्यूज़ किए हैं और कुछ चीज़ें की हैं. जो बात अभी हो रही थी स्टिग्मा की, डिजीज़ की, डायग्नोज की, रिसर्च की, तो मैं एक चीज़ पॉइंट आउट करना चाहता हूँ, क्योंकि मैं पेशेंट हूँ, मैं एक जर्नलिस्ट होने के साथ साथ जर्नलिज्म वाले बात पे भी मैं आ जाऊँगा बाद में. एज ए पेशेंट मुझे ये बताइए, आप सब लोग डॉक्टर्स हैं यहाँ पे, जो रिसर्च हो रहे हैं इंडिया में या इंडिया के बाहर दूसरे देशों में, कितने लोग अफोर्ड कर पाते हैं? क्या कॉस्ट होता है उस दवा का? आप कहते हैं हमने रिसर्च कर लिया, बहुत अच्छा है, प्रोलॉन्ग कर लेंगे लाइफ. हाउ कैन यू प्रोलॉन्ग? कैसे करेंगे आप? अगर कोई दवा 5 लाख रुपए की होगी, मुझे जरा ये बताइए कि भारत में जहाँ पे 1 करोड़ की तनख्वाह अगर किसी को मिल गई पैकेज IIT किसी बच्चे को, तो आप अखबार के पहले पन्ने पे बैनर खबर छापते हैं, हम लोग छापते हैं. 1 करोड़ का मतलब क्या होता है? डिफ्रेंशिएट करिए. 8 लाख रुपए के आसपास, 8 लाख रुपए. 8 लाख रुपए की तनख्वाह वाला आदमी 5 लाख रुपए की दवा कैसे अफोर्ड करेगा? तो पहला तो मामला, हम लोग ये काफ़ी अच्छा, बहुत खूबसूरत लगता है क्योंकि अच्छे हॉल में बैठ के बात करें कि काफ़ी रिसर्चेस हो रहे हैं. ये आया इम्यूनोथेरेपी की दवा भी, डॉक्टर पाटिल का मैंने पढ़ा था हाल ही में, वो ट्विटर पे शेयर हुआ, मैंने भी शेयर किया था. इन्होंने इनका ही वो था, ये 3% लोगों ने वो इम्यूनोथेरेपी की दवा सिर्फ अफोर्ड कर पाई. तो इस रिसर्च का क्या फ़ायदा इंडिया से कंट्री में बैठ के, अगर हम लोग यहाँ बैठ के बात करें? फर्स्ट. दूसरा जो होता है स्टिग्मा, स्मोकर होना, आपका नॉन स्मोकर होना, फैमिली के प्रेशर्स, एक काफ़ी चीज़ें हुई हैं तो मैं रिपीट नहीं करूँगा. एक चीज़ मुझे बताइए, ये सवाल आप सब लोगों से है कि एक आदमी, जैसे मेरी उम्र 47 साल हो जाएगी 1 तारीख को. मुझे जब डायग्नोस हुआ 2 साल पहले, मेरी उम्र 45 साल थी और मैं अपनी फैमिली को अपनी कमाई से चलाता हूँ. 45 साल के किसी आदमी को जो अपनी फैमिली को चलाता है किसी एक तनख्वाह पे, भारत में या किसी देश में, उसको अगर बीमारी हो जाती, लंग कैंसर या कोई सा भी कैंसर, तो क्या वो केयर, डॉक्टर साहब बोल रहे थे, वो काफ़ी अच्छी बात है, केयर गिवर पे कैसे छोड़ सकते हैं आप? आपको तो फिर प्लान भी करना होता है ना कि आपके पास फंड्स कहाँ से आएंगे, आप कहाँ जाके रहेंगे. अगर मैं मुंबई में आके इलाज कराता हूँ तो कहाँ मैं रहूँगा आके यहाँ पे, और हमारी फैमिली हमारे बाद, क्योंकि आपको पहले ही पता है कि आप इंटेंट लिखते हैं, दिस इज पैलिएटिव ट्रीटमेंट. पैलिएटिव का मतलब क्या होता है हिंदी में मुझे बताइए? ये एंड ऑफ लाइफ ही तो है एक तरीके का. आप ये कहते हैं कि हम प्रोलॉन्ग कर रहे हैं आपकी लाइफ को, आप ये नहीं कहते कि हम आपको कंटिन्यू कर रहे हैं, कि आप 70 साल की जो एज है इंडिया में, उसमें आप 70 साल तक जिंदा रहने वाले, आप नहीं कहते, आप कांट से. तो जब आप नहीं कहते हैं तो वो भी एक स्टिग्मा होता है एक मरीज के पास कि वो ये तय करे कि अगर वो नहीं रहेगा तो उसके पास की फैमिली कैसी चलेगी. सेकेंड. और तीसरा, अब मैं आपकी बात पे आता हूँ, सॉरी मैंने कुछ चीज़ें कही. जर्नलिज्म में हम लोग लंग कनेक्ट ने जो काम शुरू किया है और जो कर रहा है, ये काफ़ी बेनिफिशियल है. हमने डॉक्टर कुमार का इंटरव्यू किया था दूरदर्शन के लिए, मैंने किया था, और कई फोरम्स पे मैंने नवभारत टाइम्स में भी लिखा था, उनके एडिट पेज पे एक आर्टिकल जिसमें उन्होंने लंग कनेक्ट का काफ़ी ढंग से जिक्र किया था, और हमने उसमें भी ये बात कही थी. विवेक जी यहाँ हैं, विवेक जी को मैंने वो फॉरवर्ड भी किया था. जहाँ अफोर्ड करने की समस्या है कि आप जो दवाओं की कीमत है उसको आप खरीद नहीं पाते, अफोर्ड नहीं कर पाते. तो मेरा ये मानना है कि लंग कनेक्ट जैसे जो फोरम है, हम सब लोगों को अपना काम तो करना है, जो पार्टिसिपेट कर सकता है ऐसे फोरम्स को इंक्रीज करने में उनको करना चाहिए, क्योंकि ये एक होप है. जहाँ हम लोग होप की बात करें, एक होप है कि जहाँ कुछ भी नहीं, चलो एक होप तो है कि लंग कनेक्ट है, वहाँ जाके कुछ बात कर लेंगे, कोई मीटिंग होगी तो आपको कोई सॉल्यूशन मिल जाएगा, तो वो करना चाहिए. मतलब आप वो अच्छा है. लेकिन मुझे लगता है कि जो लंग कनेक्ट है या इस तरह के जो पेशेंट सपोर्ट्स ग्रुप हैं या जो पेशेंट एडवोकेट्स हैं जो काम कर रहे हैं पूरी दुनिया में या भारत में, या जो NGOs हैं जो काम कर रहे हैं, उनको एक प्रेशर भी बनाना चाहिए. प्रेशर बिल्डिंग का काम भी आपका ही है, और वो मैं भी उसमें शामिल हूँ. आपका मतलब उसमें मीडिया शामिल नहीं है, ऐसी बात नहीं है. एज ए जर्नलिस्ट मैं भी उसमें शामिल हूँ कि हम ये भी बनाएं कि हम एक दबाव बनाएं कि हाँ ठीक है, गवर्नमेंट प्राइस कौन तय करता है दवाओं का? गवर्नमेंट ही तो तय करते हैं, सबसे पावरफुल तो गवर्नमेंट ही है. आप किसी स्टेट गवर्नमेंट से 5 लाख रुपए दिलवा देंगे, क्या होगा? 5 लाख रुपए के ट्रीटमेंट कितना? डॉक्टर पाटिल ज़्यादा पैसे बताएंगे, मैं तो खर्च कर रहा हूँ, मुझे पता है। हमारे यहाँ झारखंड में 10 लाख रुपए तक की मदद मिलती है। और मैंने ही चीफ मिनिस्टर को कह के वो पहले वो था 3 लाख रुपए का, फिर वो 5 हुआ, फिर वो 10 लाख रुपए हो गया। अब हमारे यहाँ 10 लाख रुपए तक की मदद झारखंड गवर्नमेंट करती है वैसे मरीजों को जो कैंसर या दूसरी इस तरह की बीमारियों से ग्रसित है। तो मेरा ये कहना है कि एनजीओज का और जो पेशेंट सपोर्ट ग्रुप हैं उनका और जो पेशेंट एडवोकेट्स हैं उनका भी एक रोल है बहुत महत्वपूर्ण, कि वो ये प्रेशर बनाएं जो पावरफुल लोग हैं उन पे, गवर्नमेंट पे, जो भी उनके स्टेक होल्डर्स हैं, कि जो दवाइयों की कीमत है वो दवाइयों की कीमत इंडिया में या दूसरे देशों में, इस तरह के देशों में नियंत्रित रहे। क्योंकि आप ही रिसर्च करके अखबार में खबर छपवा लेंगे कि हाँ एक बहुत रिसर्च आई, इम्यूनोथेरेपी आई है और इसमें तो मरीज इतने दिन रह लेगा, खरीदेगा कौन? तो मेरा ये पॉइंट ऑफ व्यू है।
Dr. Patil, any views?
I think he brought about quite a relevant thing, and that's important. I think research has to be for the people, by the people, in the society. You cannot have research in which you develop, and that has been the way we have been trained. I'm the first student of Dr. Kumar, and that is the way I have been trained, that whatever you do, it should be, the drug should be such that if you Saturday or Sunday, from Monday everyone you should be able to use it. There's no point in saying that, okay, this drug is there and you did this research, but it cannot be afforded for. And this is, I'll take a minute on this. And such things can only be done by research. Like for example, what he was alluding to, that we make you have immunotherapy. One cycle will cost 3 lakhs. We may have to fund crores and crores for 3 lakhs. But if we do research and we show that, okay, even if 1/10 of the dose or 1/20th of the dose, what we showed was 1/10 of the dose, 1/20th of the dose is enough, which will bring down the cost drastically. Those efforts will go long, long way. So I think that is a very good point, that in some part we also have to think that we have to support some research, which are, I'm not talking about every drug research. What I'm trying to say is accessible researches, like which will bring down, because such research, and I'll tell the low-dose immunotherapy research we did was, I won't tell the name, but was actually supported by one of the NGOs. Because no company wants to support such research in which their profits will go down from something which is for 30 lakhs, it will come down to 30,000, so like 60 lakhs a year treatment coming down to 4 lakh or 3 lakhs per year. No one wants to do that. So that's a very good point. And there was another point in which, and I noted that somehow as doctors, and we have got into this era of saying this is curative, this is palliative. This is curative, this is palliative. I think it is time for us to palliate the word palliative. Because that palliative word carries a lot of stigma. For example, and I'll give you an example. Lung cancer, stage 3 or stage 2, when you do surgery or you do chemo radiation, the survival in many of the patients is roughly around 2 years to 3 years. Today, stage 4 lung cancer, if it's ALK positive and if you get the appropriate therapy, the survival, even though palliative, is beyond 5 years and 6 years. But unfortunately, because you put on that cost certificate, that stigma that this palliative, he won't get, and we have faced this, he won't get support from anywhere.
We have discussed this in our very early meetings, that, I mean,
so
if there is a little bit of awareness that things have changed, you cannot go by what it was.
Yeah,
and, taking the word palliative off, I think, has helped a lot more patients get funding. I think Chandu has something to add to this.
देखो, मुझे डोनेशंस जो मिल रहा है ना, वो डोनेशंस के लिए जो डोनर्स मेरे पास आते हैं या CSR कंपनीज आते हैं, बेसिकली उनको हमें कंसेप्ट देने पड़ते हैं कि हम ये फंड कैसे यूटिलाइज कर रहे हैं। तो हर एक को ये लगता है क्यूरेटिव इंटेंट पे करो, हर एक को लगता है वो बच्चों के लिए करो, हर एक को लगता है फीमेल के लिए दे दो। तो अगर मेरे पास फीमेल सपोर्ट अवेलेबल है तो मैं वो सपोर्ट उसके लिए ना यूज़ नहीं करता हूँ, मुझे लगता है कि वो दूसरे के लिए यूज़ करे जिसको कुछ नहीं मिल रहा है। तो मुझे डोनर को पहले कन्विंस करना पड़ता है। डोनर्स एजुकेशन यहाँ बहुत इम्पोर्टेंट है कि डोनर्स को मुझे बोलना पड़ता है कि यंग एडल्ट है, उसको समझो पैलेटिव हमने ट्रीटमेंट प्लान किया है, तो वो पैलेटिव का मतलब क्या है, तो यंग एडल्ट के लाइफ में पैलेटिव ट्रीटमेंट की वजह से क्या फ़र्क पड़ेगा, वो मुझे पहले डोनर को कन्विंस करना है। तब डोनर मुझे बोलते हैं ठीक है आप पैलेटिव दे दो, तो मैं उनको बोलता हूँ कि आप जो मुझे फंड दे रहे मैं 25% इस पैलेटिव इंटेंट में यूटिलाइज करूँगा, क्योंकि अगर मुझे उसको 2 और 3 केमोथेरेपी का अगर मैं सपोर्ट दे रहा हूँ तो उसको जो क्वालिटी ऑफ लाइफ है वो इम्प्रूव हो जाएगी, थोड़ा सा वो पेन जो है उसको कम हो जाएंगी। तो ये अगर उसके लिए फर्क पड़ रहा है और मेरा हॉस्पिटल उसके लिए ट्रीट कर रहा है तो मेरा काम बनता है कि उसके लिए भी सपोर्ट करें। तो हम कोई भी डोनर्स आते हैं तो उसको हम एजुकेट करते हैं कि इसको हम किसके लिए यूज करेंगे, प्रायोरिटी क्यूरेटिव को देंगे, लेकिन उसके साथ साथ यंग एडल्ट है या इस प्रोटोकॉल जो पैलेटिव उसके लिए भी हम सपोर्ट करेंगे और वो राजी हो जाते हैं। तो हमारा ये रोल बनता है कि उनको पैलेटिव और क्यूरेटिव का फर्क समझा दे, तो डोनर्स हमारे पास आ जाएंगे। सेकंड थिंग, सर की एक प्रोटोकॉल है डिसीज कंट्रोल का, उनका अराउंड 2 लाख कॉस्टिंग है, 1 साइकिल्स को 40,000 लगते हैं। तो मेरे पास पेशेंट आता है तो मेरे पास 1 या 2 साइकिल का सपोर्ट है। तो मुझे ये चेक करना है कि आगे जो
क्या होगा,
4 साइकिल लेना है तो आगे 2 का वो
कहाँ
क्या
से
करेगा?
होगा।
अगर मेरे पास है इसके लिए मैंने 1 सपोर्ट दे दिया, 2 साइकिल को दे दिया, लेकिन उसने वो 2 नहीं कंटिन्यू किया तो मेरे 80 लाख जो है वेस्ट है। तो डोनर ने मेरे पास दिए तो कुछ कॉज की वजह से, कुछ रिस्पॉन्सिबिलिटी की वजह से दिए कि ये प्रॉपर पेशेंट के लिए जाएगी और उसका यूटिलाइज होगा। तो ऐसे सिचुएशंस में मेरे जो सोशल वर्कर जो मिसेस माने जो केसेस हैंडल करते हैं सर से कनेक्ट होते हैं, सर को पूछते हैं कि हमारे पास 2 का सपोर्ट है, आप 2 के लिए कुछ अरेंजमेंट है तो हमें बताइए, हम इसको 2 सपोर्ट दे देंगे, और सर और हम वो डिस्कस करके हम डिसीजन लेते हैं। तो हर एक चीज़ के लिए हम जो कोई हमें दे रहा है तो डोनर्स एजुकेशन देके उसको इन्फॉर्मेशन देके, इसके साथ साथ पेशेंट को इन्फॉर्मेशन हमें देना है कि आप 1 साइकिल लेंगे और 3 साइकिल नहीं लेंगे तो हमारा 40,000 वेस्ट है, डॉक्टर की मेहनत वेस्ट है। तो आप भी डिसाइड करो, हम रास्ते बताते, उस रास्ते पे आपको चलना पड़ेगा। तो ये सब केस टू केस प्लानिंग करके हमें डिसीजंस लेने पड़ते हैं, तब हम जो राइट कुछ ये है यानी हम जो कुछ एक्सपेक्ट करते हैं वहाँ तक हम पहुँच पाते हैं।
डॉक्टर आज हमसे कुछ
I just want to add one thing. I do agree with the fact that the word palliative sends wrong signals. Having said that, I think if you can, when the doctor mentioned that actually puts off the funds and donations etc. So I think in the process of dropping or changing palliative, I think the patient also loses on a lot of support. So yes, if you say the treatment is, if you can drop the word palliative from palliative treatment, maybe the patient will get funds, but in the process what happens is that patients get referred really very late, and unfortunately even in the private, so I think even the rich in the country, we are all here for the interest of the patient and the caregivers, all our intentions are towards their wellness. Even in private, the richest of patients with metastatic cancer or lung cancer die a miserable death. So what I am trying to say is, yes, if we can improve fundings for patients by dropping the word palliative, but do not forgetting the intention, the ethos, the principles and concepts of palliative care. This does not happen. The problem is the minute you say drop off palliative, everything gets dropped and the patient is on his own. I have seen in the hospital I work, patients getting referred 2 hours before death, 2 weeks before death. I'm not going to make a difference. The patient knows he's going to die. The patient's relatives are miserable. They have no clue what's happening. They want to go home. There's no way to get to the patient's home. And why should he or she listen to me whom he or she has seen 2 weeks ago? Who the hell am I? It's a new face. Why should I trust this woman? How is it going to make a difference if she's sitting with me for 2 hours? So my only hope and eager, humble request is, yes, we need to get patients diagnosed early. We need to get them the right treatment, the resources, the funding, but use any other word. So the kind of words that my colleagues use is go to supportive care consultant, go to this consultant who improves the quality of life, instead of using the word palliative. By shunning the word palliative, please don't shun the whole ethos and the principle. And that is what is happening. And it's sad to see people my age dying in hospitals alone, struggling, suffering, when we can really make a difference in the quality of life till death. Because it's very important to also focus on the way our patients are dying, not just living. Yes, we want our patients to live, but like that gentleman said, prolonging a poor quality life is torture. And when we talk of research, we focus on survival. Does the survival translate to quality of life? For example, as a pulmonologist, we say FEC has improved by 100 ml. How the hell is 100 ml making a difference in a human being's life? Is it making him walk 2 steps? Is it making him go to the toilet on his own? Is he eating on his own? That is what we need to focus on. So research is good, but it has to be translated to the human being's life. Otherwise, we are spending crores in something that is going to be statistically great and publishing wise great. But we really need to make a difference. What dent are we making in the patient's life? And that's what we need to focus on. So that's my simple request.
I think that's exactly what Dr. Patil is sort of doing in a practical point of view. And as we know, the hordes of people who come to Tata Memorial, the very fact that if Mr. Parab can, even somebody from his department can even say that, listen, I have enough for 2, can you get, to get that degree of micromanagement, it just talks of the dedication that the department has. It's not easy, it's not one size fits all. The fact that they're even able to do this, I think also. Any comments on your side? And then there's a gentleman there who wants to say something. No. I think just let doctor say, and then you'll get a mic too.
I agree with her. In fact, I'm a fan of early palliative care even in curative setting. In fact,
exactly.
I have worked in Kerala, and I always used to, in Kerala, even used to refer my T1, T2 breast cancers there, because I feel, as a medical oncologist, I would have 80 patients to see, and you could only devote some 10-15 minutes per patient, but there are more aspects even in an early diagnosis where there is a social, mental, which can be taken care by palliative care expert. My only thing is that when I write that palliative care word on the cost certificate, the chances that my patient would get funds goes down. That's why we coined the term disease control, so that that chances, probability of getting his funds increases.
And as I said, palliative care now, there is the national Saath Saath helpline, so there's palliation available to patients all over the country. So I think basically, like Lung Connect, we really need to be networking with organizations who are there to support and help patients. I think we've heard the one warning bell. We will, I think, take a few. We'll pass it around for one comment each from everybody, if you have anything to say, and then if there's anybody from the audience who wants to comment.
Just a quick comment. I've been hearing with some degree of curiosity. मैं अगर कुछ गलत बोल दिया थोड़ा माफ कीजिए. इसमें एक दो चीज़ है एटलीस्ट मेरे लिटिल बिट ऑफ जानकारी के माध्यम से. हम लोग का जनरली क्या है ना मैडम, विल्स पर ज़्यादा है विल पावर से. Let's first acknowledge that. And in many ways, trying to get out into the community, trying to get early detection and get the diagnostics right in the first instance. We often don't focus on that front. अभी आपने जैसे बताया टाटा मेमोरियल में जो आते हैं, बहुत ही हालत जो जिसने भी जहाँ भी बच नहीं सकते उधर आते हैं. 70% of cases are literally end of life or very little survival. Second मैडम एक और चीज़ है कि हमको थोड़ा ह्यूमिलिटी होना चाहिए. कैंसर में बहुत सारा चीज़ हम जानते नहीं हैं. Probably we know only 5% of what the entire space of oncology is today. So long as we have the humility to acknowledge the differences, अभी किसी ने T1 to T4 का कुछ बताया, in a few years the entire staging protocol will vanish. Just as one person said, there are people who have survived under palliative for 6 years. A person with T1, T0 also has failed in 2 years. अभी रूम के बाहर हम जाएं तो a truck can knock me off and say thank you. Palliative curative कुछ नहीं है इसमें. So what we need to do is every life is important. To that extent, लोगों को विश्वास देने के लिए, if we get the detection early and get the diagnostics right, one can assure that the fellow will even mortgage his kidney and get money. घर के लिए 30 साल का 5 साल का लोन लेते हैं. There are enough and more people wanting to support if we are able to give with some degree of comfort and confidence, saying that look, you can live a life with dignity, not on XYZ. Sorry to be off track on this.
I think we can have, we've already had our bell through that time, but I think we began a few minutes late, so maybe shall we just taking just one comment from each person, please. If you can start, Dr. Amit can start from that end, and then closing from the two chairpersons.
So just because NGOs and everything, we are in a phase of evolution. मतलब हम कहेंगे कि पहले हमने treatment पे focus किया, curative पे, now obviously disease control, palliative, now toward diagnosis. The other thing is the problem with the middle-aged person is that कि they are thinking about their family. तो जो next हमारा evolution phase होना चाहिए कि जो family members है, how to support them. So we should also think of something providing them as a partial employment for them also. कि वो उनको अगर with the patient we are giving them, though they are not giving full time, even we can help them out. बिकॉज द ओनली थिंग कि उनको भी नेविगेशन चाहिए कि दे कैन गेट टू द एम्प्लॉयमेंट दे आर फिट फॉर. तो उससे वो फैमिली सपोर्ट हो जाती है, पेशेंट के का भी ट्रबल थिंकिंग ऑल दिस इम्प्रूव्स. तो इन नेक्स्ट फेज ऑफ एनजीओज आई विल थिंक दिस इज द मोस्ट इंपॉर्टेंट कि हम उनके अटेंडेंट्स के लिए भी आर स्टार्टेड थिंकिंग
Support for the caregiver, support for supporters. Dr. Jaffrey.
I think so. The hope is a good word. When I started in Tata in 1990, there was not a single NGO working as an organized sector, and today I think so there are almost 40 of them, and trying to do as much as possible in all facts of life. It's very important for people coming from out to have accommodation, finances, and everything. So things are doing better, and I think so. I hope that it will be much better in the future.
Thank you. Mr. Jain.
I would like to say that most of the medicines are coming from abroad only. So that is why they are costly. And that NGO should give pressure on the government that it should be subsidized. That should be the thing.
I think advocacy has a lot of role to play in helping with patients.
मुझे मालूम है, मुझे 30 इयर्स कंप्लीट हो गए टाटा में. जब हम शुरुआत में थे तो जैसे सर ने बोला वॉलंटियर नहीं थे, वैसे हमारे पास फंड भी नहीं थे. हम हॉस्पिटल में से उनको सपोर्ट करते थे ट्रीटमेंट के लिए. आज सब प्रोटोकॉल्स चेंज हो गए, नए नए लेटेस्ट प्रोटोकॉल्स आए, लेटेस्ट ट्रीटमेंट आई है, और उस ट्रीटमेंट के लिए कहीं ना कहीं की हद तक हम सपोर्ट देते हैं, और लोग हमारे पास आते, भरोसे से आते कि ये लोग का जो डिस्ट्रीब्यूशन है वो प्रॉपर है, हमारी सिस्टम बहुत अकाउंट्स की अच्छी है. हर एक डोनर्स को ऐसा लगता है कि मैं जो पैसा दे रहा हूँ वो प्रॉपर जा रहा है. ये देखो बॉम्बे में मनी इज नॉट इम्पॉर्टेंट, वो यूटिलाइज आप कैसे कर रहे हैं उसका यूटिलाइजेशन का प्रॉपर इन्फॉर्मेशन शेयर करो. तो हर एक डोनर्स जब मेरे पास आता है तो वो 500 रुपये दो या 5 लाख दो, मैं कितने दे रहा है कभी भी उसको सवाल नहीं करता हूँ. मैं उसको ये बताता हूँ कि मेरा हॉस्पिटल क्या कर रहा है, मेरा हॉस्पिटल क्या फैसिलिटी दे रहा है, मेरे हॉस्पिटल का आपने दिया हुआ फंड कैसे पेशेंट्स अकाउंट में जाता है, हम किसको सपोर्ट करें, जिसको मेडिक्लेम नहीं है, जिसको कुछ सपोर्ट नहीं है, ऐसे पेशेंट को. ये जब सब डोनर्स को दिखाता है तो बोलता है नहीं ये राइट थिंग है, हम यहाँ डोनेशन देंगे, और वो डोनर नेक्स्ट टाइम और 4 लोगों को लेके आता है. तो मेरे हॉस्पिटल की सिस्टम्स, मेरे डॉक्टर टीम की सिस्टम, सब लोग जो काम करते हैं उसकी वजह से हमारे पास अभी अच्छा डोनेशंस आने लगा. हम ज़्यादा से लोगों को हम पैसे की सपोर्ट दे रहे हैं, और भविष्य में भी वो मुझे डोनेशंस बढ़ेगा ऐसा लगता है, क्योंकि लोग देते हैं, कॉस्ट ठीक होना चाहिए, काम ठीक होना चाहिए. तो वो हमारी टीम कर रही है, और मुझे सब लोगों का सपोर्ट है, वॉलेंटियर से लेके एडमिनिस्ट्रेशन से लेके सब अकाउंट से लेके सब लोग सपोर्ट करते हैं, मेरी टीम प्रॉपर काम करते हैं. इसके लिए हम ये नतीजे तक पहुँच गए हैं, ऐसा मुझे लगता है. थैंक यू. और सॉरी, और एक छोटा आपने जो बोला काम के बारे में, तो ICICI फाउंडेशन है, SBI फाउंडेशन है, ऐसे लोग कुछ ट्रेनिंग्स देते हैं स्किल जो किसको ब्यूटिशियन का हो या और टाइप का, और हम उनको ये सजेस्ट करते कि आप ये जो ट्रेनिंग दे रहे हो वो बॉम्बे में मत दो. हर एक लोगों को क्या है बॉम्बे में ही आना पड़ेगा वो ट्रेनिंग लेने के लिए. अगर हमारी सेंटर्स जो ऑल ओवर उधर चालू हो रही, उस एरिया में अगर आप ट्रेनिंग देंगे और उस एरिया में उसको काम देंगे तो वो अच्छा रहेगा कि उनको हाथ में कुछ स्किल्स आएगा और थोड़े बहुत पैसे मिलेंगे.
काफ़ी है स्किल डेवलपमेंट जो
चल रही है,
पर्टिकुलरली स्किल डेवलपमेंट फाउंडेशंस काफ़ी कर रहे हैं जो अलग अलग जगह में वो लोग बता रहे हैं.
कुछ ठीक है. और एक बात जो मैं ऐड ऑन करना चाहता हूँ, जिसकी चर्चा थोड़ी बहुत हुई है, लास्टली में ये कहना चाहता हूँ, जो टाटा मेमोरियल हॉस्पिटल है मुंबई का, जहाँ हम सब लोग ट्रीटमेंट लेते हैं, मुझे कई बार लगता है कि मैं हॉस्पिटल में ना आके यहाँ टेम्पल में आ रहा हूँ, मंदिर है. ऐसे टाटा के ही कई सारे डॉक्टर्स हैं, डॉक्टर गुंजेश हैं रांची में, अच्छे डॉक्टर यहाँ से गए हैं, और दोस्त भी हैं हमारे, तो हम ट्रीटमेंट ले सकते हैं. ठीक है, एक बार लगता है नहीं चलो मंदिर घूम आए, तो इस तरह मुंबई आ गए और मंदिर घूम के चले गए. तो मुझे लगता है कि इस तरह के और सारे मंदिर होने चाहिए भारत में, हॉस्पिटल्स जिन्हें हम टेम्पल कह सकें.
Last line that I would like to say is this is towards the clinicians and the caregivers when they talk to the patients. It is trying to tell them that this is a battle that you're going through, but there are going to be micro battles in them. It's overcoming each day at a time, sometimes each hour at a time, and sometimes for a matter each minute at a time also. Because from here till survival is a journey, but there are going to be struggles and battles in between them. Try not looking at the bigger picture. Try overcoming one day at a time and face those micro battles, small battles, overcoming them. Eventually, the goal has to be reached eventually.
I would like to say that from the diagnosis to end of life care, that quality of care is important, and to address the issues so that throughout the cancer journey, that patient, caregiver, and the family should be relieved every way. And this is a holistic approach. So this is the teamwork, not only the clinician, but all are involved there, and that everybody's duty and work is there to that relieve the distress and that to comfort the patient every way. So thank you for inviting me here. Thank you so much.
As I said earlier also that the word hope, that hope is very, very important. Every patient has to keep a hope that day by day, as I said, that research is going on. So maximum survival life, we have done the studies and it was showing up to the 5 years to the 14 years. So definitely by doing the research and we get the knowledge about that, definitely that survival life will also increase up to the 20 to 25 years. So believe on that, and regarding always motivating about the others also during the cancer, that if you do the yoga, definitely that due to yoga, that for the lung, specifically for the lung, oxygen is very, very important, which improves your lungs. And by doing the pranayam, your surviving life is also going to be increased. That is sure. And lastly, I would say that this Lung Connect group is already doing the very well, and I want that it should go spread everywhere in the worldwide.
Yeah, it should happen with support of people like you and motivation of people like you.
I think the bottom line is teamwork. Like I said before, we are all here with one intention. And instead of calling it palliative, curative, we all need to wear these different hats at the same time. And since our goal is towards patient wellness, we really need to work together and probably enhance what's already going on. You know, all of you have the intentions of doing good work. Instead of inventing your own different wheels, it's time to kind of garner support, channelize all the energy into one direction, because otherwise it's like a story of what, like we in Tamil say, you know, Samudratle Peringayam Karchakadai. It's like trying to dissolve asafoetida in the ocean. It's not going to get to anybody. So I think we really need to focus on this and not say this is palliative, that is curative, or focus on what is the best interest of our patients and what our patient wants. Because in the medical training, the concept of medical ethics, communication, and talking about death and dying doesn't exist. It started now, and so we hope we have a bunch of doctors who are compassionate and kind and understand the needs of our patients and caregivers, and therefore work towards that. And it's lovely to see that so many non-medical people are interested in making a difference in the community, and it's really heartening to see that you're happy to contribute towards this good cause. So let's work together, and I think that's what's going to make a difference in the end.
Thank you everyone. Any closing remarks from the chairperson? Dr. Patil had to go out, I think, to take a call.
Hello. So this has been a really wonderful discussion, very ably led by Usha. I think you really guided the entire panel from the beginning to the end of how a patient actually goes through their journey. So I had been asked to just give a few conclusions on that. So for each of them, it's very hard to really do a conclusion of the discussion here. So I would just like to take a few words from each person. So Dr. Amit Kumar talked about how the patient journey actually starts, about how much difference there is between metros and rural areas and the problem of abandonment. The asking the patient, do you really want to take the treatment? What are the investigations? Advising them on how to start that journey. Mr. Parab talked about the information regarding funds available at Tata and how best to garner, to use the funds that the patient has to try to go from beginning to end. Dr. Patil talked about the diagnosis and staging, fitness testing. It's not just about diagnosis, especially in lung cancer. It has changed, and all of these things have to be taken into account before deciding what is the appropriate treatment. Lekhika talked about the role of the MSW in Tata and looking at the emotional problems beyond the physical problems also. Looking at the trauma that the patient goes through along with the caregiver and providing motivation to go forward. Mr. Jain spoke from the caregiver point of view. He said it's very difficult to accept, but groups are important and community support goes a long way. Dr. Sameer gave an amazing point of view. We often wish that doctors would understand what patients are going through, and he spoke about that. He spoke about the importance of hope. I think everyone spoke about hope, but how important also it is to accept and to trust the doctor. Dr. Rajam came up with a brilliant phrase, the clock ticking backward. I think that is something that we all have to keep in mind as far as cancer is concerned.
I think clock tick backward for everybody.
Yes, that's true. But it's, when you're diagnosed with cancer, like the gentleman at the back said,
you could be knocked down by a bus.
Exactly,
like you said, you can be knocked down by a bus. So the clock is ticking.
But that clock is, the hands are more clear when you have cancer.
That's a perception.
Yeah.
But that is the perception we need to drop.
Yeah. So then the importance of complementary therapy, especially yoga, was something that Mr. Havaldar came up with. And he also spoke about the incremental increase in survival, which I thought was a very important thing. That even if you can improve your survival, because there are newer therapies available, that it could become important. Mr. Ravi Prakash talked about pressure on government to make drugs affordable. All NGOs must get together to do that. Dr. Patil spoke about research to be for the people, by the people, and the need to change the terminology of palliative care, which resonated with all of us, I think. We should talk more about the quality of life rather than the quantity of life. And I'm forgetting now who said it, I think maybe Dr. Ayaroli talked about how giving partial support is of no use, that we have to make sure that when we are giving support, it is end-to-end. Palliative care is very difficult. It should be done as early as possible. And then we also said that maybe a good terminology to replace palliative care would be disease control. And research must translate into a change in the patient's lives. Yeah?
Thank you.
I think when I said by the word clock ticking backwards, it's the budget. Nobody budgets suffering. Even in a curable disease, the patient and caregiver undergo a lot of suffering. So it's that suffering, which could be physical, emotional, psychological, that nobody budgets for. The suffering probably in the bus hit accident is more for the caregivers who are left behind, not for the patients. I think suffering is something nobody budgets for. Yeah. And nobody
I think we are running out of time. Maybe you can discuss this later individually. Yeah. Thank you very much, everyone, for your time. We've overrun. Try very hard to stay on schedule. Thank you.